总共多少张？可能40张，最后一页我看一眼，可以最后一页。可以，就是进。
Good morning, everyone. Yes, it's my great pleasure to have all of you come here to have this World Food Congress in Hainan, Boao. And this session is about the clinical features and clinical management of influenza. It's my honor to co-chair with David Hui from Hong Kong, and I'm very glad that physicians and scientists from all the world will give lectures either online or in this meeting room. I noticed that most of the attendees from mainland China, and also our speaker also from Hong Kong. So I will talk in Chinese. 不勉强啊，大家因为这。
Actually, I believe today we are hosting this conference in China. It's an international conference, but most of the audience are from the cities in China. They are the physicians and the CDC professionals. This session is about influenza and some clinical issues. Actually, I believe for physicians and clinical doctors, we should work with CDC professionals. When I talk about influenza, we will talk about public health. And today, you can see in the morning, we have 5 sessions. Only one session is about clinical. And I believe I'm from the respiratory department. We believe influenza in terms of its importance and its damage done to the patients. And it's not about the upper respiratory tract, it's about the whole process. At the same time, after the influenza bacteria and the virus infection will have the bacteria infection as well. And I believe you should look at the different process, and it's about the invasive process for our lungs and pulmonary fungal disease. And we should talk about how we can provide the treatment for our patients. And in this process, we should see how we can help our patients. And today we are focusing on this topic, and we can talk about the whole process and treatment. And in terms of the fungal disease and the influenza and our clinical treatment for clinicians and clinical professionals, we have suffered some misunderstanding. Even the doctors in USA, in the past 2 years, I engaged in ETAs, the pulmonary fungal disease guideline infection. Today, we have also invited Professor Barbara Jones, who is the leader of this research of the pneumonia diagnosis. And we should think about how we can put all of the influenza treatment into our guidelines in terms of the influenza virus diagnostics. How we can start the early stage treatment is not a one-size-fits-all solution, and we should look at how we can discuss with each other in terms of the clinical research, and we should look at the clinical rules and the clinical evidence from clinical to clinical diagnostics. it will take a long time. For diagnosis, it will take a long time. As the CDC professionals will say, we have the solid evidence, and we believe for the vaccination injection, we can reduce the major cases and the mortality rate. However, we should think about the effectiveness of the vaccination. We have the knowledge gap, and in this process, we should think about what we can do to promote the high quality evidence, and we should think about how the evidence can benefit each patient. And that is my opening remark and the brief. I'm very honored to invite Professor Xu Chang, David Hui from Hong Kong, Hong Kong Chinese University. Welcome.
It is my great pleasure to introduce the first speaker, Su Xin. The topic is post-influenza invasive pulmonary fungal disease. So, Dr. Su, please.
好的，感谢徐教授的介绍。我们关注流感这个问题呢，应该说不仅仅是由
Professor David, and we should look at its infectiousness and mortality rate and some clinical results. As the session chair, Mr. Cao Bing, has mentioned, we have some fungal and bacterial disease. As a respiratory doctor, in terms of the fungal disease, I have some personal research. I want to share with you the specific influenza-associated pulmonary aspergillosis, ISPA. And over the past 100 years, you can see we have the major disease, influenza in Asia. You can see the major death cases. And you can see in terms of the death rate related cases, we should look at complications and the related cases. In the early stage, half a century, 50 years ago, I believe, in BMJ and some domestic scholars for the influenza, especially H1N1 case, as the first case, a 51-year-old female housewife with secondary pulmonary aspergillosis infection following the bronchopneumonia due to influenza. She died. During SARS, we have 3 cases as well. And you can see 39-year-old suffering from the disease of the coronavirus, and this medical professional has died as well. Unfortunately, influenza and H1N1, they can cause different disease. And you can see we can have the 4 cases here, and you can see they have suffered the major disease of the influenza B. Only one has survived. However, due to the complications, they have died. That is why IAPA is a term for it. They have caused the attention, caught the attention of the scholars across the world. In recent years, you can see that we have different reviews and literatures related to it. And many researchers have been focusing on this part. In China, you can see. And what are the major specific bacteria and pathogens? Influenza is very common, and you can see the major disease related to IIPA, and in 2021, our team has written the literature overview to illustrate the early diagnosis of influenza-associated pulmonary aspergillosis. And in recent years, we have been focusing on IIPA. And in the early stage, when we talk about IIPA, we believe it's about the tumor patients, and some AIDS and other immunity-related patients. And one we realize is related to influenza and the virus is in the past 10 years. And you can see the several research here in Chest and other magazine in 2020 data. And you can see if we put all of the influenza patients together, IIPA rate 0.17%. And this is a low number, right? If we put the heavy or major disease on the right, it's about 5% to 10%. We should focus on the severe influenza disease case. They will be related to IIPA cases, including those with some fundamental disease. If we have severe influenza, they will also suffer IIPA. In 6 years ago, in Lancet, they have also focused on IIPA research from 2009 to 2016 in 432 patients with influenza admitted to the ICA. 83 cases have been diagnosed with IIPA, and you can see the rate is about 19%. And you can see if we put all of the fundamental disease and some immunity-related disease related to some pulmonary disease and diabetes, they will have 32%. If those have underlying immunity deficiencies, in this way, for IPA, it's not a low number, right? For those without any underlying immunity deficiency, the rate is 14%, and for fatality rate within 90 days, 51%, and this high mortality rate in severe influenza combined with pulmonary aspergillosis is over 20 or 30% for the regular disease. On the left, 16.9% is the combined aspergillosis infections, and 30.6% combined with non-aspergillose infections, other disease related to different bacteria. And on the right, for the mortality rate for IPA is about 66%. For the other complications, 23.7%. And you can see the results are quite severe. For this kind of severe mortality rate, it requires our attention, right? Even though they have no underlying conditions, the mortality rate is not very low in 2017. In Blue Journal, you can see our research. Over 100 severe cases, 23 cases have the aspergillosis. Some have underlying conditions. For the 7 patients without no underlying disease, they are healthy. However, they have 71% of the death rate, mortality rate, because of the delayed diagnosis. The delayed diagnosis of IPA has caused this kind of death rate. In IPA, we have some very special case, ITBA, invasive transbronchial aspergillosis in our upper bronchial. And you can see in terms of the invasive transbronchial aspergillosis, And you can see in the trunker and the branches, some of which can penetrate the airway wall and spread to the surrounding lung. Parenchyma and bronchoscopy can reveal the transbronchial ulcers and nodules and pneumomembranes. In Blue Journal and CID, we have released these papers, and these two researchers have told us for ITBA, in terms of the observation, we have 27% of the incidence rate, and some of the patients have not been diagnosed. If we have the ITBA severe rate, it's 90% of the mortality rate, and for the reference, it's about 32%. Even though it is about the bronchi, the mortality rate is very high. On the right bottom, top right, each time they have the case, you can see it's very. However, we should look at the CT scan. In China, we have two excellent research in 2021 and 2022. For Professor Deng Qinyuan's team at China-Japan Friendship Hospital, the incidence of IPA in patients with severe influenza was 31%, and the mortality rate was as high as 58.5%. In West China Hospital, the mortality rate of severe influenza is 22%. After complication with IPA, the mortality rate has doubled as high as 52.8%. For severe results, we need to look at the early stage diagnosis and early stage treatment, and we should also look at the risk factors for those influenza severe cases who are vulnerable to IPA. In the Lancet magazine, you can see we have some factors analysis. For hepatitis 2, if the score is very high for the male, if they have used some hormone, and you can see the IPA rate is very high. If they have no underlying conditions, after suffering from influenza, the IPA rate has increased from 5% to 14%. We should focus on those with immunodeficiency and for those without immunodeficiency. IPA rate has also been tripled. For the influenza, why it is vulnerable for IPA? For coronaviruses and pandemic, and for the up cells and the wall and the airway, you can see influenza virus may cause the cell-mediated damage to the airway epithelium and interference with normal mucociliary, and in this way, the immunity would be lowered and compromised. For PTX3 expression, I have been doing some research, and it has some production of the aspergillosis, and however, for the cell PTX3 expression, some influenza virus can inhibit PTX3 expression, which may be one of the pathological mechanisms of the patient's susceptibility to IPA. And you can see it is an important part of the immune response, and it can induce production of PTX3 and some influenza types such as H1N1 with this activity. And that is why it is a multi-factor incidence rate. And then for glucocorticoid treatment, and it is not recommended. Once you have used it, and you can see you suffer the damage, and you can see it will cause the extra death rate, and it will also reducing the anti-inflammation effect for those with some inflammation case. The early stage antivirus, some inflammation can be controlled. The early diagnosis and early treatment is expected for the patients with severe influenza and aspergillosis. If it's too late, the mortality rate would be rising. And for diagnosis, it's not so easy. And you can see you should focus on the different clinical results and the imaging features. For IPA, based on the influenza, it's not so easy to differentiate. For Harrow sign and L-carnitine sign, it's very rare. And you can see we have some imaging and a shadow on it. We should look at the risk factor analysis to predict it. And our team has done some research in the early identification of patients with severe influenza-associated aspergillosis in the intensive case for those with the hormone with over 200 mg. And for lumbar cell, you can see the multi-lung hydrosign. And we have some scoring. If it is 11 in the scoring, it has 80% of the IPA risk. The higher the score, the higher the risk. You can see the Asper price predicts IPA risk. We should look at the pathogen analysis for the patients, and we should also look at the cultivation. And for the diagnosis and its sensitivity, it's not very sensitive enough for those severe disease. We should look at the severity of the serum GM in patients without pneumonia. That was significantly reduced. Now look at some guidelines. The number is 1. For BAL, GMI should be higher than 0.8%. 0.8, it is able to achieve the desired diagnostic efficiency. And for the GM, it is over 0.5. For some blood disease and from transplantation disease, for the blood GM is over 0.5, for BAF is 1 or higher than 0.8. Now look at the nucleic acid test and the PCR sensitivity is higher. For the Aspergillus SPP and species, and you can see BAF and the periphery blood for NGS, they have the value as well. We can detect the aspergillosis and other fungal disease. We should look at the investment and output, and we simply look at some pathogens and the PCR. For some complicated cases, NGS has the advantage. In 2020 Intensive Care Medicine magazine, we have the IPA diagnostic process, the IPA international guideline. If it is a severe case outside of ICU, we should have done some tests, and you can see the blood and the BAF GM and cultivation and some bronchial treatment, and we should look at the picture and imaging. And once we have gotten the evidence, and you can see the specific process, in this way we can reduce the mortality rate. I want to share with you that in the clinical process, some people have not been admitted into ICU, and they have not suffered the cases, but they suffered PMD and other severe cases, even though they have very slight influenza disease with infection. You can see some white lung and severe disease. They will have some fever and continuous coughing, and we should also look at the IPA. It's not about the antivirus treatment and the antifungal treatment, and then they can be shifted. A summary. And in this process, in the severe case, IPA has caused our attention for the glucocorticoid treatment before admission to the ICU will be one of the independent risk factors for severe influenza disease combined with IPA. For other risk factors, we should have further research. And for the imaging, you can see, in addition to influenza, we have some new imaging, seasonal infection, and some of the imaging effects are not so related to our research, but we should have the GM test and PCR test and nucleic acid test. We have the early diagnosis and treatment and reduce the mortality rate. This is my research. Thank you.
Still have about 1 minute or so for questions. Anyone from the audience have questions?
就是您认为就是流感继发的
In the influenza season, for the clinical science issue, what is the most important science research topic? How should we carry out our science research topic related to the influenza? I believe on the one hand, we should improve the clinicians' awareness and perception for some respiratory disease and some ICU and some emergency treatment. They learn about it. Once we have learned about the IPA and the severe cases, we should have the microbiorganism research and test. And in this way, most cases can be identified. And we should also do some research. In this way, we can have some very accurate and efficient way for the clinical application. In this way, when we have large number of patients, we can have the immediate response and treatment. In clinical studies, for those with some glucocorticoid, their aspergillosis are so difficult to treat. We have the repeated test of the BAF and it's positive. We use the standards and some antifungal treatment. They will have some breakthrough infection as well. That is the observation based on all patients. Do you have some similar awareness and perception for this kind of patients? What is the best way for the anti-aspergillosis treatment is different from the regular ones? In terms of the treatment, I believe we should look at the joint treatment. It should be related to the conditions. For the severe case, we will take some extreme measures and some anti-inflammation drugs, antivirus drugs as well. We'll look at whether it is related to the immunity inhibition, and we should also look at the imaging results and the flu related. And even though we have done everything, we will witness some specific cases of the mortality rate. Maybe our treatment should also be enhanced.
Speaker is Dr. Tim Yoiki of the US CDC. Unfortunately, Tim is not able to come, but he has actually sent a pre-recorded lecture on the WHO influenza treatment guidelines, limitations and gaps. The guideline is actually being reviewed internally by the WHO, and it should come out in 4 to 6 weeks. And there are also 2 papers coming out in the Lancet on the topic also. So let's look at the lecture, pre-recorded lecture by Dr. Tim Yoiki.
The 2024 guidelines update the 2022 guidelines that were posted on the WHO web pages. These were based upon consultations that occurred in late 2023 and early 2024. The methodology that was utilized was the grading of recommendations, assessment, development, and evaluation, or GRADE framework. And these were focused on randomized controlled trials. In support of this, WHO commissioned systematic reviews for antivirals and immunomodulators. And for antivirals, the commissioned reviews were network meta-analyses. And the guidelines incorporated minimally important differences, or what well-informed patients would consider clinical benefit for the outcomes of interest. Minimally important differences were defined as the smallest difference in score in the outcome of interest that informed patients or informed proxies perceive as important, either beneficial or harmful, and which would lead the patient or clinician to consider a change in management of the patient. The 2024 guidelines cover non-severe influenza in outpatients and severe influenza in hospitalized patients, and include seasonal influenza and zoonotic influenza recommendations. During the next influenza pandemic, WHO will issue specific guidelines. The recommendations address antiviral treatment, adjunctive therapies, and diagnostic testing strategies. Based on the strength of the evidence, a strong recommendation was worded, "We recommend." If the evidence was not quite as strong, a conditional recommendation was made and was worded as, "We suggest." Minimally important differences for outcomes of interest were as follows: admission to hospital 15 per 1,000, mortality 3 per 1,000, mechanical ventilation 10 per 1,000, adverse events 10 per 1,000, length of hospital stay 1 day, and time to symptom resolution 1 day. Now I'd like to summarize the recommendations, and I'll first start with antiviral treatment of non-severe influenza in outpatients, and particularly those who are at high risk for severe complications of influenza. The only antiviral for which a recommendation was made for use was for baloxavir. This was a conditional recommendation for use based upon low quality evidence, and the wording was as follows: we suggest administering baloxavir. And again, this is for high-risk persons. For the neuraminidase inhibitors, for oseltamivir was a strong recommendation against. For lenacapavir, a conditional recommendation against. For peramivir, a conditional recommendation against. For zanamivir, a strong recommendation against. For the antiviral umifenavir, a conditional recommendation against. And for favipiravir, a strong recommendation against. Now moving to antiviral treatment of non-severe influenza in outpatients for low-risk persons, persons who are not at high risk for progression to severe disease. There were no antivirals that were recommended to use. For baloxavir, in contrast, for high-risk persons in which antiviral treatment with baloxavir was recommended, for low-risk persons, there was a conditional recommendation against baloxavir. All the other antivirals recommendations were the same as for high-risk persons. That is, for oseltamivir, a strong recommendation against. For lenacapavir, a conditional recommendation against. For peramivir, a conditional recommendation against. For zanamivir, a strong recommendation against. For umifenavir, a conditional recommendation against. And for favipiravir, a strong recommendation against. For antibiotic treatment of non-severe influenza, this is for patients with suspected or confirmed non-severe influenza virus infection, so uncomplicated influenza in outpatients, and those with a low probability of bacterial co-infection. The guidelines development group made a strong recommendation against, based on low quality of evidence. We recommend not administering antibiotics. For antiviral treatment of severe influenza, this is influenza requiring hospitalization. The only antiviral that was recommended was oseltamivir, and this was a conditional recommendation for oseltamivir treatment of severe influenza, but the evidence was of very low quality, and the guidelines development group, the wording of the recommendation was we suggest administering oseltamivir. For the other two antivirals in which there were some RCT data available, peramivir and zanamivir both had a conditional recommendation against their use. Now, switching to adjunctive treatment of severe influenza. So, severe influenza in hospitalized patients. So for macrolide antibiotics, a conditional recommendation against was made. We suggest not administering macrolides. For nonsteroidal anti-inflammatory drugs, a conditional recommendation against the use of NSAIDs was made. We suggest not administering NSAIDs. For mTOR inhibitors, a conditional recommendation against was made. We suggest not administering mTOR inhibitors. For passive immune therapy, a conditional recommendation against the use was made. We suggest not administering passive immune therapy. And for corticosteroids, a conditional recommendation against was made. We suggest not administering corticosteroids. Now of note, for all adjunctive treatment of severe influenza, the quality of evidence available for all of these drugs was very low quality evidence. Now moving to antiviral post-exposure prophylaxis of seasonal influenza, and specifically this is for persons at extremely high risk of severe illness if exposed to seasonal influenza viruses in the prior 2 days. So this is not for all persons who are exposed to seasonal influenza viruses. It's only for those who are at extremely high risk. So this is the most high risk of the high risk persons. So for the 3 neuraminidase inhibitors considered, oseltamivir, zanamivir, and lenanimivir, there was a conditional recommendation for all of these drugs based upon moderate quality evidence. So we suggest administering oseltamivir or zanamivir or lenanimivir. For baloxavir, there was also a conditional recommendation for, based upon moderate quality evidence. We suggest administering baloxavir. Again, this is only for persons at extremely high risk of severe illness if exposed to seasonal influenza viruses in the prior 2 days. Post-exposure prophylaxis of seasonal influenza. Now, moving to the same topic, but for persons who are not at extremely high risk of severe illness if exposed to seasonal influenza viruses in the prior 2 days. So, in contrast, for all 4 of these drugs that had a conditional recommendation for persons at extremely high risk of severe illness for antiviral post-exposure prophylaxis of seasonal influenza, all 4 of these drugs, oseltamivir, zanamivir, lenanimivir, and baloxavir, had a conditional recommendation against based upon moderate quality evidence for each of these drugs. Now moving to antiviral post-exposure prophylaxis of novel influenza A viruses associated with high mortality in infected people, or those novel influenza A viruses of unknown risk of severe disease. And this is exposure that occurred in the prior 2 days. So for all 4 antivirals that were considered, oseltamivir, zanamivir, lenanimivir, and baloxavir, there was a conditional recommendation for, based upon low quality evidence for all 4 of these drugs. And of note, the evidence was indirect. It was for seasonal influenza. It was not, there were no data for novel influenza A viruses. So these recommendations were all based upon indirect evidence from seasonal influenza. Now moving to testing. For influenza testing of outpatients, and here only for persons at high risk of severe seasonal influenza, not persons at low risk. So regarding point of care influenza nucleic acid amplification assays, also referred to as molecular assays, or utilization of influenza digital immunoassays, there was a conditional recommendation 4 based upon low quality evidence. Now switching to severe influenza, so for influenza testing of hospitalized patients with suspected severe seasonal influenza, regarding influenza nucleic acid amplification assays, so PCR or other molecular assays, and this is also based upon using test and treat, so utilizing testing to then administer antiviral treatment to all patients who are positive. A conditional recommendation 4 was made based upon low quality evidence. Now, there are some caveats to this recommendation. If nucleic acid amplification test results are rapidly available, this is the preferred strategy. However, if PCR results are available within 24 hours, then a PCR wait is a reasonable approach, and then one can initiate treatment when those PCR results are available, if they are positive. Now, if PCR results are not available within 24 hours, then a PCR treat approach may be a reasonable approach. So you start treatment, and then you get your result, and if it's negative, then you would stop antiviral treatment. Now I'd like to discuss some of the limitations and gaps. The recommendations for antivirals were based on the findings of network meta-analyses of randomized controlled trials that included both direct effects of one antiviral and indirect effects of other antivirals. And network meta-analyses can lead to conservative estimates and underestimate of the effects of one antiviral compared with traditional meta-analyses of randomized controlled trials that only assess the direct effects of one antiviral. And this can result in different conclusions, and as an example, I refer to oseltamivir treatment of non-severe seasonal influenza or in outpatients, and this could lead to different recommendations. So traditional meta-analyses, both in adults and children, have reported actually significant benefit versus placebo, reduction of more than a 24-hour improvement in symptoms versus placebo. And although this reduction was lower in high-risk persons, there was a 63% reduction in the risk of all-cause hospital admission. So if one just referred to traditional meta-analyses of randomized controlled trials, probably this would have met the minimally important differences for both low-risk and high-risk patients for oseltamivir treatment. And similarly in children, a traditional meta-analysis of randomized controlled trials found that although in all patients, oseltamivir treatment only reduced symptoms by a median of 17.6 hours versus placebo, which would not meet a minimally important difference. But when you excluded children with asthma, the reduction was a median of about 30 hours versus placebo, which would meet the minimally important difference. So for seasonal influenza, in terms of severe disease or for patients who are hospitalized, there are actually very few RCTs that have been conducted for antiviral treatment of severe influenza. But there are many, many observational studies of oseltamivir treatment of influenza patients who are hospitalized. This has been accumulated for many, many, many years, both before and after the 2009 H1N1 pandemic. However, the WHO guidelines did not consider any observational data for antivirals, even though for sure observational studies are not considered to be as high quality of evidence as randomized controlled trials. However, when you look at all these observational studies of oseltamivir treatment of severe influenza, they do suggest clinical benefit of starting oseltamivir treatment as soon as possible at hospital admission. And so those studies provide the rationale for recommendations of many guidelines around the world for empiric antiviral treatment of patients with suspected influenza started at hospital admission. There's also very limited data on combination antiviral treatment and immunomodulators. There are only some very small trials. Definitely this is a data gap, an evidence gap, and larger trials are needed. Regarding limitations and gaps of antiviral treatment of novel influenza A virus infections of zoonotic origin, there are no randomized controlled trials of antiviral treatment of patients with non-severe or severe disease from novel influenza A virus infection. The WHO Guidelines Development Group did not consider any observational studies, but there are observational studies that have been published of oseltamivir treatment of patients with avian influenza A H5N1 or H7N9 virus infections. And these studies suggest survival benefit of early treatment initiation. There are no data for other neuraminidase inhibitors or baloxavir. And single-dose baloxavir treatment, such as what seasonal influenza dosing is for outpatients, may be insufficient for novel influenza A viruses associated with severe disease, such as H5N1, H5N6, or H7N9 viruses. And there are no data for combination antiviral treatment of patients with non-severe or severe disease. Furthermore, there are no randomized controlled trials of antiviral post-exposure prophylaxis of novel influenza A virus infections. There are no observational data that have been published. And if you apply the post-exposure dosing for seasonal influenza, and for example, for oseltamivir, that is once daily, or for baloxavir, that is a single dose, that may actually be subtherapeutic if novel influenza A virus infection for viruses associated with severe disease is established. So for example, again, H5N1, H5N6, H7N9. And if you give post-exposure prophylaxis dosing the same as for seasonal influenza, this might increase the emergence of antiviral resistance with monotherapy if infection is established. For example, the CDC recommends oseltamivir treatment dosing for post-exposure prophylaxis of household contacts and other non-household close contacts of a symptomatic patient diagnosed with H5N1. And we would do the same for household contacts or close contacts of a patient with H5N6 or H7N9 virus infections, because these viruses are associated with high mortality in infected humans. And there are no data for zanamivir, lenanimivir, or baloxavir for post-exposure prophylaxis of novel influenza A virus infections. So there are a lot of limitations and gaps if you just apply data, indirect data for seasonal influenza to novel influenza A virus infections. With that, I'd like to thank you for your kind attention and wish all of you good luck with managing your influenza patients. Thanks so much.
So that was a brief summary of the new WHO treatment guideline for influenza. So please watch out for the publication and also the 2 papers in Lancet in 4 to 6 weeks. The next speaker is Dr. Huiling Yan of the Hong Kong U School of Public Health, and her topic is anti-NA antibody responses in the general population, imprinting and cross-reactivity. Dr. Yan.
Good morning, and I would like to thank the meeting organizers for the opportunity to present our work today. So it will be focusing on the hemagglutinin, which is the major antigen. So through this talk, I hope I can convince you that the neuraminidase is also a very good target for generating antibody responses. So as mentioned, the very good correlate of protection for influenza is antibody, particular HAI antibody at 40 or above 40, right? So this has been adopted as vaccine preparation for a long time. And antibody also can be generated against the neuraminidase. So as you can see here, although it is not as abundantly expressed on the virus surfaces as the HA protein, directly those antibodies can inhibit the sialicase function of the neuraminidase and then blocking the ability of the virus to spread effectively. So similar as the neuraminidase inhibitors, as we just heard. And in addition to that, there is FC-mediated antibody function, so including ADCC. So those can also confer protection. So recently, there are multiple observational studies and human challenge studies have demonstrated that there's a good correlation between the anti-NA antibody titers versus reduced viral shedding, reduced disease severity, and also in a household transmission study, it was shown that a correlation of high baseline anti-NA antibody can block transmission, in particularly in young children. Another benefit is that neuraminidase evolves much slower compared to the hemagglutinin, and often you will see a so-called discordant antigenic drift between the two surface glycoprotein. So in this regard, if we have anti-NA antibodies, it may actually protect us against a heterologous challenge against antigenically mismatched HA. So our antibody responses is actually quite dynamic at the individual level and at the population level. So each of us, since we were born, right, we are actually under risk of repeated influenza infections throughout our lives. However, our first encounter with the influenza virus is going to determine our subsequent antibody landscape. So this is a phenomenon known as immune imprinting, because the first time when you're exposed to the influenza virus, your memory B cells and T cells will recognize this first virus very well. In the subsequent infection, even though you are encountering a new virus, your memory B cells and T cells will actually be recalled and redirected to the first virus that you are exposed to. So we are always imprinted by our first influenza virus infection. And because influenza actually evolved very rapidly, we are constantly facing antigenic drift and antigenic shift variants through either epidemics or pandemics. So people born at different times, in different years, our first influenza virus infection is actually different, right? So for example, I was born in the mid-70s, I will be exposed to a different virus compared to people born in the 90s. Right? So that's going to shape the total population level dynamics antibody responses. So the outline for my talk today, so actually this is two studies done by my PhD student, currently a postdoc in the lab. So we are quite curious about these imprinting responses. Previously, the imprinting responses are well studied for the anti-HA antibodies, but very limited study has been done for the anti-NA antibodies. So we are quite interested to understand what is the spectrum or the landscape of the antibody responses for both HA and NA from the same person against H1N1 viruses. And in the second part of the talk, I would like to show you that we actually can detect a very good level of anti-NA antibody response against the H5N1 clade 2344B viruses that's currently circulating globally. So like I mentioned, we are always affected by our first response to influenza infection, and this was very nicely shown in early times, known as the antigenic scene, original antigenic scene. And those were usually done just measuring the anti-HA antibody responses. So we are curious to know if the NA antibody responses is going to have a similar pattern as the anti-HA antibody responses. But to do that, we need to know how the antigenic changes occurs among the N1 proteins. Because usually, HA antigenic changes are characterized every year through vaccine updates, right? So every year we will get a new updated strand of influenza vaccine, but that is only based on the HA antigenic drift. We are not focusing on NA antigenic drift, so usually people don't characterize them, whether there's a drift or not. So we firstly set up the goal, we want to know a comprehensive antigenic evolution of the neuraminidase subtype N1 from 1977 to present day. And then we will use those information to compare the anti-HA and anti-NA antibody responses from the population. So this diagram shows you the variant pandemic strands over time, right? So for example, if a person was born in the 1950s, that person will be likely exposed to an H1N1 or H2N2 virus as the first strand of being infected. But if a person that is born after 2010, he or she is going to be exposed to H3N2 and H1N1. So, knowing that, previously there were a few studies characterized antigenic drift variants, but the information was not very complete. So we decided to complete this information by further characterize very early antigenic drift variants from 1977 to 1991. And this is the antigenic characterization for the neuraminidase is done by this assay called ELA. So this is, as you can see here from the screen, we will coat photoin on the plate, and the neuraminidase will cleave the photoin, and then if the galactose is exposed after sialic acid is removed, then we can detect galactose through this PNA and then have a signal. But if you have an antibody response blocking the enzyme site, the cleavage will not occur, and then you will not see that signal. And then we were using a panel of ferret antisera that was raised after infection of different variant strands. And then using that, and then the ELA assay, we can actually identify there were 3 major antigenic groups. So that's the USSR 77, and followed by the Singapore 86 virus, and then followed by the Texas 91. So those 3 are the major antigenic variants for the N1 over the time. And then we were also interested to identify what is the amino acid residue leading to this antigenic drift. So we focused on 4 particular antigenic sites that was known for the neuraminidase. So that's position 247, 369, 386, and 344. And eventually we identified that one mutation at N386 actually leads to this antigenic drift. So if we look at the phylogenetic tree, this position actually is quite oftenly changed in the N1 neuraminidase. So like I mentioned, the USSR 77 has a N at 386, and this is associated with an N-glycosylation site. And in 86, this position is actually mutated to K, and then leading to an antigenic change from USSR 77 to Singapore 86. And this is subsequently changed from K to D in 1988, and then that is associated with antigenic drift in the Texas 91. And also interestingly, in the parallel, the pandemic H1N1 also has the same position in the antigenic drift. So we have the California 2009 virus drifted in the neuraminidase to Michigan 15, and then that was also associated with the N386K mutation. So now we have a comprehensive list of HA variations, antigenic variants, and also NA antigenic variants. So we determined population serological responses to the HA and NA. So a total of 130 people, healthy people from age 5 to 70s were tested for this assay. So through this assay, we can actually see that there is a strong imprinting. So basically, people born, you will be imprinted by the virus that you were first exposed. So we know this for HA already. But similarly, you can also see that a similar response for the neuraminidase antibody as well. And in particular, this is suggesting that perhaps the first time you are exposed, the age, is between around 10 years old, within 10 years old, that you will encounter your first exposure to influenza. Another benefit, what we've seen here is that NAR antibodies actually have a better cross-reactivity compared to the HAI antibody. So this is a heat map, and you can see in the y-axis is the birth year, and in the x-axis is different strains. So if we look at the people, 130 of them, how many of them actually develop a higher than 1 to 40 HAI antibody titers? It's about 67% of them actually will have more than one HAI antibody to more than one HA antigen. But many of them actually have high, 1 to 40 NAI titers against more than one NA antigen. So this suggests that NA is really much broader, much cross-reactive across different strains. And that can be a benefit if we include it in a vaccine composition. So the second part is that we were interested to understand the antibody responses at the population level against H5N1 as a part of the population immunity assessment to the risks of a potential pandemic for the H5. So we learned from the talk from Professor Chen Hualan yesterday and from Dr. Richard Webby that the global spread of 2344B has led to more than 300 poultry being called, right? And then there's also multiple mammalian species got infected, not just humans, but also multiple mammals. So we wanted to see at the population level, do general population possess any antibody response against H5N1, 2344B viruses? So we determined the HAI and NAI titers among 63 healthy adults, aged 18 to 73 years old, and those sera were collected in 2020, okay? And then the virus we were using was a local isolate from Hong Kong. It's a clade 2344B H5N1 from wild birds. So the sera from 2020, as you can see, in general, none of those people has HAI antibody against H5N1, although we have very good antibody titers against pandemic H1N1. So the pandemic H1N1 is shown in purple color. The response to the H5N1 is shown in green color. Yeah? So HAI antibody for pandemic is good, but none has antibody against H5N1. The NAI antibody titers, as you can see, interestingly, we all have a pretty good NAI antibodies against the H5N1 at a similar percentage and similar geometric mean titers as the pandemic H1N1 virus. So after seeing these results, we were quite curious, wondering why do the population have antibody against H5N1 NA, right? So we thought that the NA of the pandemic H1N1, we think about it and think, oh, it was an avian origin, if you remember, reassortment of the H1N1. It was a Eurasian swine lineage, and which was coming from avian species originally. So we asked the question, if we collect serum from population before the 2009 pandemic, can we see antibody responses against this H5N1? So in this case, the 2009 population sera was very low, not reactive to the H5N1 NA. And this is also further confirmed using ferret sera. So those are sera infected. And then you can see that those infected by seasonal H1N1, they do not have a cross-reactive antibody response for the H5N1. But the ferret sera infected by the pandemic H1N1 virus cross-reacted well with the H5N1 virus. And we also tested with other avian viruses. So this includes another H6N1 virus and another H6N4 virus, which is in the group 1 of the N1 family. So we can see cross-reactivity to H6N1, but no cross-reactivity to the H6N4 virus. But interestingly, even though we see a very good cross-reactivity, there is still quite a lot of amino acid differences if we compare the H5N1NA versus the pandemic H1N1NA. There is still about 53 amino acid differences with amino acid homology at 88% only. So in summary, immune printing, I show you that NA drifts less frequently than HA, and we identify a mutation at 386, which is associated with a glycosylation site, leading to antigenic drift. And we observe age-dependent imprinting for both anti-HA and anti-NA antibody responses, with peak HAI-NAI antibodies detected in subjects about 4 to 12 years old at the year of virus isolation. And the NAI antibodies were more cross-reactive than the HAI antibody responses. And we also detected high titers of cross-reactive NAI antibodies against the clade 2344BH5N1 virus. And infection by the pandemic H1N1, which possessed an avian origin NA, was associated with the induction of the cross-reactive NAI antibodies against the H5N1. And of course, the in vivo protection of those anti-NA antibodies need to be further investigated. So our results support the use or the need to include NA as an antigen in the seasonal influenza vaccine preparation. So finally, I'd like to thank the funding from Hong Kong government and my colleagues from Hong Kong U and collaborators from CDC, University of Illinois, and the Creek Institute. Thank you.
So we have a bit of time for one question. Anyone has any question? Yes.
Thank you. Good presentation. I have a question. My English is not good. Yeah, we know NA is good antigen, and the NAI inhibition are good and cross-protective among different strains, but in fact there are not very small amount of preclinical trials use NA for antigen. Do you know why? And can you? Yeah, we also try to use NA antigen to make universal vaccine. But can you tell us what's the advantage or disadvantage of this antigen?
Thank you. Yeah, so yesterday I think Professor Hainan also mentioned about monoclonal antibodies against the neuraminidase. It's being tested. So I can see that, there are more evidence. So there will be more clinical evidence, I think, building up to show the role of the anti-NA antibodies. And maybe as a starting point, it would be good to start considering incorporating the NA component in the seasonal influenza vaccine as a starting point. And I think there will be more animal experiments perhaps to show the benefit and more human studies to show the benefit of the anti-NA antibodies will be helpful. Yeah. Thank you.
Thank you, Dr. Yan. So the next talk is to be delivered by my co-chair, Dr. Chao Bing, who needs no introduction. So he's going to give us an update on the progress in clinical research on respiratory viruses in adults in China.
非常感谢 David 的介绍，感谢大会邀请。
Thank you. Thank Thank you for the kind words of introduction. Today, I'm going to talk about the long-term health outcomes of acute virus infection. I'm Cao Bing. I'm from the China-Japan Friendship Hospital. These are the major topics of my presentation. Actually, for all along, people have some misunderstandings regarding the acute respiratory virus infection. Some people believe that it will just take 3 to 5 days, or at most 1 week, the infection will go away, including influenza, including the corona Omicron. But from science perspective, when we think about it, whether it is true or not, is it true? I think many people have this kind of feel. If you have some acute infection of the respiratory, sometimes you feel that it will take much longer time for you to recover from the fatigue. For instance, you feel very tired and you can't just get back to the normal status of work or life. That's maybe just a rough impression. Maybe you're affected with the influenza. You don't have deeper understanding regarding the acute infection. What are the health outcomes after influenza? About 100 years ago, for the very first time, there was influenza around the world in 1918. Then doctor noticed the encephalitis, and there was a sudden increase of the encephalitis incidence, and also there was increased incidence of narcolepsy. This was the study by the Beijing hospital, and according to this research, Professor Han Feng and the team have found that there was increased incidence of the narcolepsy in 2010 linked to the pandemic or epidemic of influenza. And also there was another study, pandemic influenza H1N1 infection was associated with a more than twofold increase risks of CFS or ME. Of course, whether there was the causality, we need more work to prove it. And also some people have realized that influenza was also associated with diagnosis of a Parkinson's disease more than 10 years after infection. And there were also some other studies which suggested the psychological relationship, including depression, anxiety, and also the quality of life can get worse, especially for those who have received ECMO. After the recovery period, the quality of life was much worse. And also, among the H7N9 survivors, lung functions improved over 2 years after discharge from the hospital, but there were changes in terms of the restrictive and obstructive patterns on ventilation function test persisted, and also the physical and emotional domains in the SF36 were worse than matched general population. So basically, acute virus infection is not just for the short term, rather it will have a long impact in our lives. Probably it has the benefit, or I mean, it has the advantage on the whole body or multi organs, including lungs, etc. And we know that right now we have the coronavirus A, I mean the SARS-CoV-2 infections. The WHO experts have organized a round of the questionnaires regarding the COVID or the long COVID. So according to the WHO definition, if these symptoms persist after 3 months of the infection, and it could last for about another 2 months and cannot be explained, then this is a long-term the COVID infection. So actually, it is not the short term. It includes influenza and other types of the respiratory infections, etc. So WHO, NICE, and also NASEM have studied about the COVID-19. Now the consensus is that there is the long-term impact for the acute virus infection. Actually, this is a very busy chart. I don't want to go into the details, but you can see for different countries, including US, the UK, Canada, and also China. From all these studies, there suggest that after the acute virus infection, the long-term persisting symptoms are there, and probably around 10% of the patients will have the long-term symptoms. And we can see in terms of the original strains can even have longer symptoms comparing with the current Omicron. We have found that in 2022, the Omicron affected patients had nearly symptoms after the infection, and the percentage of the patients with persisting symptoms can be as high as 8%. So that figure for US is 10%. So this is very similar. What are the symptoms of the infection? So different studies have told us that the major symptoms are fatigue or muscle weakness, difficulty in sleeping, and some patients have hair losses and also palpitations and also chest pains. And we also looked at the patient with the long-term infections. What happened with another round of the infection? What happens to the prophylaxis? And this was published a study. We found that for the long COVID survivors, actually, long COVID is a kind of a disease. So if you have another round of Omicron infection, 76% of the participants with the long COVID at 2 years were reinfected, which will have the similar conditions. We can see if they were reinfected, there were significantly more severe, and also compared with the non-long COVID patient, those with the long COVID had a higher proportion of pneumonia. And we can see that this is the improvement of the lung function, more significant in critical survivors compared to those moderate to severe from 6 months to 1 year follow-up. And also, we have found this kind of patient, the lung function wise, we have found that observed a decline trend in lung function from 1 year to 2 years, faster than that in general population across all scales. So this is very similar to the study of the influenza. We have found the lung function of the discharged survivors was comparable to that of the matched community. And also we have noticed the changes of the lung function comparable to the Omicron-infected survivors and matched controls. And also we have found some neurological manifestations. So in this study, we have found that the cognitive impairment lasted for 3 years after COVID-19 for some patients. Because we know for this round of COVID has been going on for 4 years, but the impairment of the cognitive has lasted for 3 years. We still will last longer. Maybe you have this kind of question. Maybe these are just symptoms. Are there any objective proofs to show or manifestations regarding the neurological aspects? Actually, from the MRI, we have found some abnormal signals for the brain fog. And we have found that the brain fog, etc., is related to the infection. And most recently, this is the US study, which has completed the 3-year study. So the outpatient and hospitalized survivors were studied. We have found that even for the patient with the light infections at the 3 years end, there are some still unhealthy conditions. If we look at the study from 1918 to 2019, so if we compare the two studies, if we compare the diseases infections at different times, we have observed the clinical manifestations. For instance, fatigue, dyspnea, and also decreased lung infections, etc. And right now, for the long-term study, what is the most difficult part? We hope that we can have more study regarding the mechanisms for our team for the early patient. We have studied the proteomics. We have compared the blood samples. We have found 4 major recovery modes of biological processes uncovered. We have found some abnormal situation. So as you can see, this green line, that means recovery after 1 year. For the second group, we found that they haven't recovered at 1 year and recovered to 2 years. But there are 2 protein patterns. This abnormal infection has lasted more than 2 years. What are the signals are most obvious? Fc receptor related signal pathway not recovered at a 2-year follow-up, and also several neuron related pathways persistently suppressed across 2 years after infection. And also the proteomics and also the neurons are abnormal. And also we are studying the persistent virus remnants. For the design of this study, because in 2022, we had a mass infection around the country. Then at that time, because we have already designed the clinical trial for this patient because of the sudden infection of the virus, of the COVID, some of the operations were postponed. But 1 month after the infection, they come back to the hospital and to ask whether the postponed operations can be reinitiated. So these SARS-CoV-2 still exists in multiple tissues of the human body, 1, 2, and 4 months after infection. And we have found that the detection rate of a viral RNA decreases over time. So even 4 months after infection, we can still find 11% of the patient with the detection rate of the viral RNA. So we used to think that acute infection will go away in a short period of the time, but as you can see, 4 months after the infection, the viral RNA still exists. So people do believe that this is a response. Actually, this virus hasn't really disappeared in this patient. Then we also found that for many patients, after the acute respiratory virus infection, the virus can stay in the body far longer than our expectation. And according to our analysis, we have found that genes related to antiviral immune pathways are downregulated. In other words, so the patient thinks that he is recovered, but actually in his body, this kind of a reaction towards the virus still exists. And this study has been published on Lancet. And also, this is a paper published on innovative medicine, and we have observed dozens patients, especially with the immunotherapy patients such as leukemia, etc. The repeated infection can be called chronic active SARS-CoV infection. Just now, I have mentioned some extreme cases are some patients such as lymph oncology. They have used the CD20 mono antibody, and for the virus cannot be detected in the B cells. For this patient, the virus still exists. And also, we need to study the autoimmunity. This study comes from the Yale University. And this study has already been pre-published. Actually, in this study, it has found that the purified immunoglobulin or IgG samples from the long COVID individuals reacted with human bone tissue, but not against non-neural tissues. IgG were cross-reactive with mouse, etc. Antibody reactivity to sciatic nerves and meninges correlated with patient-reported headache and disorientation. For the antiviral drugs, we have to consider two things. We have to consider vaccine. For instance, the relief of the symptoms of the patient will benefits the patient. And also in this pandemic, with the 3 doses of the vaccine, the chances or probability of having the long COVID will largely decline. And also for some medicines, antiviral medicines, sometimes we say we use 1 dose or use 5 days. For certain types of the patient, maybe this is not enough during the acute infection period. Probably we need to extend the period so that the virus can be completely cancelled or to get rid of, because a lot of them are related to long COVID or long influenza. But sometimes we feel it's strange. Sometimes for oseltamivir, so 5 days for all patients, this is reasonable. People understand this, that this patient, people's immunocapabilities are different and his weight is different, underlying conditions are different. So 5 days of the treatment, is it reasonable? I think that for different individuals, we need to have a personalized treatment plan. To conclude, as for the long-term health outcomes of acute virus infection, we have just kicked off the study. We need to work together with our colleagues, both home and abroad. So virus infection is not a short-term process. Rather, it is a acute infection process and then to a conversion process. So we need to understand this like this. I would like to thank my colleagues, Mr. Wang Yeming, Ms. Gu Xiaoying, etc. Thank you very much for your gracious support.
So, any question for Dr. Chaobin? One question.
I would like to thank Dr. Cao Bing. So you have done the studies regarding patients. So when you talk about long COVID and after the infection, you have studied the mechanisms. But for the viruses, for instance, for the early virus of the COVID, comparing with the Omicron, they are more easily to cause the symptoms. So what are the factors related to this? This is a very good question. We just observed the clinical symptoms. Yes, indeed. We didn't analyze the difference of these virology of the original strain and Omicron strain. But I think that when the infection happens, sometimes they have severe symptoms or even they have to receive the ICU treatment. So we have found that for the acute infection, the severity is related to long COVID. So that is why I'm using this foundation, using this as the foundation of my study. But for the virology, etc., the RNA and also the protein expression of the virus, maybe they are related. Thank you very much for your question.
好，非常感谢那个 David， 还有感谢刚才的问题。我们接下来呢，我们进入我们
David and the questions. Now we're going to kick off the second session. The next speaker is Ms. Zhao Shunyi. So she will be talking about antiviral clinical research on respiratory syncytial virus in children.
Let me share my slides. Thank you, everyone. Thank you, Professor Wang. Thank you, Professor Chao. And thank you for your kind invitation. And the topic here is about ISV research. I want to tell you the clinical trial of Cherry phase 3. ISV is an important cause of hospitalization and death cause of the children under 5 years old. It causes a special disease called bronchitis, that is acute infections, bronchiolitis, which is many misfated dyspnea, but 150,000 deaths caused by ISV infection in the world. At the same time, it can also be related to asthma and repeated wheezing in the future. In China, because China is one of the countries with the most ISV. Based on our data, in China, in terms of the ISV case, accounting for 18% and 27% of the world's total. Due to the ISV infection, today we have 2,500 hospitalization cases. You can see we have about high ratio of ISV, 270% of ISV, for 8.1% in the school-age children. And you can see 4.5% in adults. ISV can cause the acute infection, and it can also cause asthma and recurrent wheezing in the future. And for those with ISV infection within 5 years, it could cause asthma. For those non-infected patients, they have higher probability, and recurrent wheezing will be changing with age. For ISV infection, it is a very important factor for the recurrent wheezing. At present, for ISV, there is no special antiviral drug for ISV. We can only treat it based on the symptom. We can have the interferon available for our country, but it's not recommended across the whole world. In USA, ribavirin is not routinely recommended because ribavirin needs continuous inhalation to be effective, mainly for patients with immunodeficiency disease such as the stem cell transplantation. And we believe you need to find out the effective drug. It can be said that at present, no, for bronchiolitis caused by ISV infection in children, even the whole adult does not have a specific antiviral drug for treatment. And we need to infect the disease from entering the epithelial cell of our airway. It also has the function of inhibiting the fusion between cells. It can prevent the virus from being released from infected cells to uninfected cells. So it has a double effect. For the cherry trial shrinking developed by the Alkabay company, this is a small molecule inhibitor for SPF fusion protein. We have 2 stages. The first stage is observation of the safety efficacy. The second stage is about the study and research. And for the kids within 1 or 2 months, and before 32 months, 64 hours, 63 hours before joining the group, and the onset of ISV within 7 days. And Mr. Wang's scoring method has a quantitative bronchiolitis score in the first stage, and the second stage, we have the random grouping. It is 2 to 1 in terms of the comparison of double-blind control, and we observed 54 patients. And you can see we have 5 days of the drugs. And you can see you have 2 doses. Today, we should observe its changes, and we have in the first stage 54 patients observed, all of which were same as the second stage. A drug was given 2 different doses according to the weight for 5 days. The main observation is the change of the daily score, and we take throat swab to see the change of the virus load. In the second stage, we have 2,048 cases we included in to observe the efficacy and safety. The main point is to look at the change of quantitative score of bronchiolitis, which was 48 hours after taking the drug, and the secondary main focus was the decrease of viral load at 96 hours. Capillary caused by children's infection with zinc. Its main symptoms are increased breathing and dyspnea. In addition, there are irritability and lethargy caused by hypoxia or toxic encephalopathy of the nervous system and the feeding differences. Because of the lack of oxygen, the child breathes badly and he will have feeding difficulties. This kind of children often have wheezing sounds in both lungs. Even without stethoscopy, we can hear wheezing sounds, and you can see the experiment was designed as stage based on our country, and for ISV, we should look at the trials. The qualitative indicators were set according to the guide of ISA of FDA in the US. We use Mr. Wang's scoring method recognized by the whole world, and the main indicators including in the scoring system, the frequency of breathing, and another is the mobilization of ventilators, that is auxiliary ventilators and mobilization of auxiliary breathing after hypoxia, and the 3 main characteristics as well as the way the wheezing sounds are heard or not, as well as the general situation, including whether the child is irritable, whether it have difficulty to eat or feed, and whether it is drowsy. There are 3 or 4 indicators, each of which has a negative score of 1, 2, 3, and only those with the total score greater than or equal to 5 are enrolled. This is the overall enrollment situation. We see that the children under 6 months account for 62.5% of the whole experiment. The third phase of pediatric experiment is currently difficult, and the proportion of children under 6 months is the majority, so the experiment is still difficult to look at the gender and age. I won't introduce him anymore. I look at the subtype, A subtype, and the B subtype, and look at the major indicators based the scoring system, and to look at after taking the drug after 48 hours. The ones scoring, look at the scoring after 48 hours compared to the placebo control. The p-value is equal to 0.02, and the score value is reduced by 0.8 point. Although it is reduced by 0.8 point, we should see from its reduction range, and the medication group should be more than the placebo group by 30%. And for IC treatment, the younger the kids, the more severe the case of the infection. We see the kids under 6 months, they are more beneficial from the whole process. From the experiment, we know that the children under 6 months are included in this group, and as I mentioned now, accounting for 62.5%. We look at the children under 6 months based on statistics from 48 to 72 hours compared with the placebo. The quantitative indicators are also different. Let's look at some changes in all indicators. From the change of the third sign, as well as the change of breathing frequency and the records of wheezing sounds, there's also general change, which is a convergence of all age groups. line refers to the children under 6, and let's look at the various indicators. Children under 6 months benefit more, and there are obvious indicators for number 3 symptom, respiratory frequency, and wheezing sounds, especially under 6 symptoms. The p-value is 0.0023 for different indicators. For those under 6, they can benefit more. Under 6 months, they can benefit more. For number 3 symptom and respiratory frequency and wheezing sound, we have the statistical differences for those under 6 months. That is why we can say the statistical p-value is 0.023. These are the major indicator, and look at the secondary indicator. For the viral load, from 48 hours to 80 hours after taking the drug, compared with the placebo, the decline of viral load in the experiment group is obviously different from the placebo group. We have the statistical differences observed. If we compare the two groups, the drug group, the virus load is decreasing by 70% more. This is the lowest number. And which is the number of the people who have not been detected, and the lowest exceeded our lowest line. And let's look at the drug group. And after 96 hours, the second indicator, we see that 27.15% of the patients in the drug group cannot be detected, and 13.616% in the placebo group. As mentioned, for children after RSV infection, you should not only pay attention to the incidence and mortality rate of the severe disease. We should also look at the recurrence after RSV infection. The experiment has also designed for the future recurrence of repeated wheezing and asthma after RSV infection. At this point, we observe the incidence of wheezing after RSV infection of kids under 6 months. Of course, we haven't been following the diagnosed asthma because we should look at follow up the average numbers for the drugs and follow up treatment. We have 15.33 months, the placebo group 17.1 months, and we have 78 groups in the drug group and 38 patients in the placebo group. For the drug group of the wheezing recurrence rate, it is 16.7%. For the placebo group, 31.6%. We should look at the standards, 2 times of the recurrence rate diagnosed by the doctors. The expected number each year, for each person, the average incidence of wheezing for drug group 0.19%, placebo group 0.54. That is why for the clinicians and our drug supervision department are very careful about this indicator. After RSV infection, we have anti-RSV infection, and you can see the repeated wheezing and asthma. For this part of the result, we are still following up. You can see the result is quite amazing and surprising. According to the adverse drug reactions, they are safe. There are no severe adverse drug reaction. After 4 days stopping taking the drug, you can see for the placebo effect, we have 4 to 4 cases. For 1 or 2, grade 1, grade 2, we have the side effects of the drug. You can see the ratio. If it is 2% of the incidence rate, the symptoms are diarrhea and the liver enzyme transmania increase, and the occurrence of rash and the decrease of platelet and the increase of platelets and the increase of the myocardial enzymes. In addition, there's a diagnosis of the functional dyspepsia in our pediatrics and hyperkalemia. And I believe although the incidence of diarrhea in the drug group seems to be higher than that in the placebo group, there is no obvious difference in terms of liver function damage. There are rash and other higher incidence of the skin disease. Dismap. The third phase clinical trial in this result is quite amazing, and for kids under 6 months, the benefits are more, and there are preliminary study. It can also reduce repeated wheezing in the future, and in the future, it will be the promising anti-ISV drug. I want to say thank you to 30 hospitals, over 30 hospitals, and their support. In this way, experiment can be done. That is my introduction. Thank you, dear professors, and thank you, Professor Cao. Thank you to the host. Thank you to the audience. Thank you, everyone. Thank you for your time. Thank you, Dr. Zhao. And over 30 hospitals, pediatric department professionals, thank you for your contribution and your support, your clinical research and joint efforts. We hope that this inhibitor can be put on the market to benefit those kids. Next speaker from the
topic of his presentation is the research and development process of antivirals against influenza and COVID-19 from a clinical value perspective. So thank you, Mr. Cao. So
the China-made drugs. So OK， 我想讲一讲，因为时间比较紧张。
Rest for time. So I'm going to speak Chinese. China's drug development has been progressing fastly. We have the patient-centered guidelines. So what is patient-centered? I think that if you are English speaker, probably you don't understand this expression of patient-centered. But for the Chinese doctors, we know that we wanted to emphasize the efficacy. So the first story I would like to share is that we have this study. We have already here. So we have talked a lot about this kind of stories. For influenza, I think that you are very familiar with this. In China, we needed to emphasize the influenza as well as the COVID. They are integrated. And also we're looking at the unmatched in China. So we have the flu A and also for flu B, and for children, mostly flu B. Just now, Professor William talked about the story, and I'm very much interested in it. And also in China, we have the avian influenza. Actually, in that publication, we talked about 5 cases, and 3 patients used inhibitors and 3 died. So what happened? From the neuromyelitis, we look at the preliminary inhibitors. So for Baloxavir, so there are 8 going on in China regarding the clinical trials, 3 phase and etc. But we look at the contrast, so PA, PB1 and PB2. We do believe that PB1 is not that mature. PB2 is mature. From the Johnson company, they have terminated the study. So that is the background. So we have the 3rd generation of the influenza drugs focused on RD/RP. And we have noticed that this is a current status in China. And there are a lot of studies going on. And there are evaluations regarding the molecule, for instance, for oseltamivir, etc., for the novel drugs, PB needs to do a lot of work. So the clinical treatment requires innovative drugs because we want to emphasize the novel targets to overcome the inefficacy, etc. So DSP 1273. So we work together with chemical compound scientists. So we talked about H1N1 and also H3N2. And we do believe that there are a lot of improvements comparing with the 787. And we noticed 2 things. So, and we have ZSP 1217, and also we have the VX788, and also we have presented to CDE. During this study, we have done the ferret, and actually for China's drug R&D, there is no requirement for ferret study as it is very expensive, but I still insist on the ferret model study. Then for the phase 1 clinical trial, we are very lucky. We have found that the number 1273, it is very safe for the bioavailability, and also the safety is also very good. And this is very safe and also tolerate among the healthy patient. And in this process, as this was before COVID, and that was done in 2019, we did the phase 2 study. So actually in 1.5 the season, we have done over 170 cases. As you can see, we have done the phase 2. Actually, for H1N1, for 600 milligram QD, we can make it shorter again than principal group. I think that for hours, we have reduced by 20 hours, and we have seen hope in the phase 2. So actually for the Johnson one, it was terminated, but in China, we have proven it, and we have seen the viral load because COVID didn't happen at that time, and the multi-center, there are PCR tests and etc., and also a lot of qualitative tests. But in this process, we have found that the viral shedding clearly has been shortened. And actually for NA inhibitor, we rarely see drop down for human beings. So for China-made PP2, we have seen this situation. We are very lucky. The safety is also very good. And also we published this study on Lancet. We do believe that we are very lucky. The number is not that big, over 177. So we published this study. I was actually, so they hope that we can publish and continue the research for the phase 2. And for phase 3, it is also a multi-center. We're even bolder because this is made in China. So we do the head-to-head. And for the time, baloxavir was not in China, hasn't been in China yet. And for this study, we have done the study over 700 patients, and we have seen that we see again, it can relieve the symptoms more obviously. And also we did some other trials for the same target. Some, for instance, P-Modivir, we did the comparison. We have found that improved rate is much higher because we didn't do this test simultaneously. We just analyzed the data. Well, for the viral load, and also viral culture, viral RNA, etc., we did found that it can shorten the period of the viral shedding, and we see again on human body, and we did the comparison again, compared with Ravish. This medicine has already been approved by CDE, and for P-Modivir, and also Tamivir, the result is not good. So overall, this drug is safe and effective. That is first case. So a short summary, we meet the needs of the patient domestically and also internationally. This is our point of departure. We also have to think about the future, whether we can have the new option for the combination therapy, such as including PA, PD, and also Doratus, etc. And also in China, we have the traditional Chinese medicine. I think it's worth doing. And for the second story, it's the protein inhibitor, which is called Larotravir. And also we have the generation 1, generation 2, etc. For anti-COVID, we have the Remdesivir and a product from Merck and etc. And Pfizer is very important. China is also working hard to catch up. Well, in this process, we know that this drug needed to plus Rotamivir. For this drug, this is very effective. It can improve the exposure, but for the underlying patient who have to also use the drugs for the cardiovascular or diabetic or asthma patient, we need to consider about this. And we participated in the screening, and Professor Zhong joined in this study. For the drug, it has changed a lot. We tested its efficacy from the Y type to the Omicron, and we know that DA5 and also EG5, where EC5, etc., we focused on 1216 for the PCC, and in this process, we did some animal experiment, for instance, regarding the Delta strain. Basically, it's effective. We just talked about the clinical value, whether it is the same as a Pfizer. For instance, we needed to little Navi. I would like to really thank the partners from the structural biologists. The result is that they are very different. So we have the enzyme life study. This really helped. We have found that the bonding time comparing with the PA, it's much longer. It can reach 104 measures with the safety study. We did some strategic plan, and also we see greater safety, etc., from mice to primates and etc. In phase 1, we have found that if this medicine at 200 to 600 mg, and we can see the half-life can reach 9.6 hours. So far better than the original drug, which indicates that the single drug would work. And in Hainan, so I do think that it was really in Hainan, in Sanyang. Then we have the first, actually we did 23 groups in double blind. We have found that in nucleic acid test return negative CT value parameter, we have found that the single drug can reduce by 5 days comparing with the placebo. So this is really promising, and human studies are really important. So Hainan really gave us some exciting news, and we published the study in 2023. And for the first time, it is China-made. At the very beginning, it has to bond with litrovir, but after the structural biology through the enzyme dynamism, and we tried the single dose. In clinical 3, we seized the opportunity of the global, the national study of the COVID, and as you can see, this is joint study of different centers, and the result is very exciting. Actually, this is a very basic study, and in phase 1, we were inspired, and we got more confidence in phase 2, and also in phase 3, we have proven that for 400 milligrams, it can reach 1.2. So that means the single dose, the single drug works. The DDI worked. The structural interaction worked. And also we have reduced that by 11 log. For this work, this is very exciting. And just now Mr. Cao Bi mentioned, and I echo him, COVID is different from influenza because it has the ACE2 receptor widely distributed, persisted for a long time. If this continues, the drug resistance will be unavoidable. So we have already seen some published paper citing some data to say that the occurrence of the PF, CPV2, etc., and the drug novel 16, 60, 60V, etc. Now we did some mutation strains. After the study, we wanted to know for the small molecular drug resistance, does it work? So this is a foundation for our basic research. I think that for this work, for China's antiviral drugs, apart from the clinical research, we need to get the results from the basic research. For instance, the bonding capability with enzyme, etc., or the joint drugs, etc., and also some types, etc. So whether we can use the single drug, and in terms of the structure, etc., and also enzyme dynamism, etc., we can be inspired and we can inspire the doctors. But most importantly, for the high-risky group, we need to avoid DDI. So DDI is not a simple issue, and it can come back to the DDI of litrovir. So actually, after 18 months of the clinical trials, actually in month 20, with the direct leadership of the academician, we got it on the market. So for influenza and COVID, we have 2 drugs from the basic science to the clinical study and to have the final product. So I think that we needed to unite with everyone so that we can really get down to the study. And I think that is the strategy for China's antiviral drugs. I would like to thank all the academicians, including academician Zhong and also Yao, and also our team. Thank you so much. Very exciting and very inspiring. So do we have any questions from the floor? So well presented. So we would like to thank Professor Zifeng again. The next speaker we have is Barbara Jones from US. As I have mentioned, She will be talking about the pneumonia, impact of the pandemic on pneumonia.
And critical care physician from the University of Utah healthcare system and the VA healthcare system in the United States. Thank you very much for having me today. I'm excited to talk to you about the impact of the pandemic on pneumonia care. It's a mixed method study of the VA healthcare system. So a quick outline. I'm going to talk a little bit about a personal theme of learning from variation, which sort of drives my research passion. Learning from the pandemic specifically, and then talk about some preliminary results of a study that we're conducting across the VA healthcare system on the impact of pandemic on pneumonia care, specifically the use of antibiotics and steroids. So here are my disclosure of interests. I have no relationship to commercial entities. Opinions represented are my own. I have grant funding from the Veterans Affairs Hospital System and the Center for Disease Control and the Gordon and Verity Moore Foundation. The U.S. VA healthcare system is the largest integrated healthcare system in the United States. It serves 6 million U.S. veterans across 140 hospitals and thousands of clinics across United States territories. And I love it because it has great healthcare data, because it has a shared electronic health record across all of those settings. So personal kind of research theme is I love to learn from variation. So I'm from a rural area in the middle of the United States, and I love to get out and see how medicine is practiced, not just in the university kind of academic centers, but outside in many different rural settings. And one of the wonderful things about the VA system is it does serve a lot of rural patients across the United States. And I love to look at large healthcare data networks and see kind of how practice is changed across different settings. And even across a river, you know, in a different state in the United States, the practice can be really different. So that's kind of my theme. And just a little bit, I've also been studying pneumonia for about 15 years now. And one of the interesting things about pneumonia was that before COVID-19, there were some changes in our paradigms of how we understood lung infections. So the first thing is that we used to have a really simple model of lung infection, which was basically we thought that the lungs were sterile below the vocal cords, right? You can still see this in some of the medical school textbooks. That the lung infection represented actually an invasion of a sterile space. But now, thanks to microbiome research, thanks to new diagnostic tools, we now understand that the lung is actually teeming with microbes, and it's a very complex adaptive system. And lung infection in that model does not actually just represent invasion. It's actually got lots of resident microbes interacting with host cells in very complex ways. And so we've moved from a simple model to a complex one, where lung infection represents more a disruption or a dysbiosis of a natural balance that we need to restore lung health, not just by killing microbes, but by actually trying to restore the balance that was there before. And so it's also become a change from just a pathogen or a syndrome focus to looking at the host response, because especially what COVID kind of helped highlight is that there was even before COVID, an emerging kind of emphasis on understanding the host. And so we had early attempts at understanding and targeting host immune responses. And we had a diagnosis and management that was really challenged by heterogeneity. So it was very difficult to distinguish between virus and bacterial infections. We also had many non-infectious diagnoses that looked like pneumonia, like infectious pneumonia. And then we also had this variation in the host response that was really challenged our ability to understand the disease process. We also had lots of challenges with implementation of evidence-based practice. So even in the clear things that really don't seem to make sense, like broad-spectrum antibiotic use, there was a lot of challenge about this was originally something that we promoted, and it was very difficult for people to detach themselves from using lots of broad-spectrum antibiotics in pneumonia. Also, we saw very inconsistent use of objective severity assessment and really lots of variation across different settings in the hospitalization risk. So the interesting thing about pneumonia is that when you look at the evidence-based practice guidelines, they actually have a long history. They've got very, high buy-in. There's a lot of implementation kind of around them. There's performance measures that are built over those guidelines. But when you look at the standards of care, they're really only supported by low-quality evidence. Despite this, implementation of CAP guidelines as a bundle almost always improves care, either built into an order set or built into a paper-based guidelines. There is this magic that happens when you implement those guidelines. And so I like to call it implementation under uncertainty, where we have a really strong culture of implementing those guidelines that actually has a lot of evidence as a whole, but each element of that bundle of care does not actually have a lot of evidence to support it. So other problems with pneumonia that were occurring before COVID-19 were this heterogeneity and poor characterization. So one big challenge is that we really lack a lot of good diagnostic tools. And so we had these blunt ways to categorize patients. So one by pathogen, but 60% of the time, at least, this is from a CDC study, showed that there's very few people that actually get a diagnosis of a pathogen. So over 60% of the patients never get a pathogen identified. 24% of the patients, this was before COVID, were viral, and then 14% were bacterial, but you can see quite a bit of co-infection between viruses and bacteria both being detected in the same patient. And then we had these sort of blunt ways to characterize the host response. And so we had sepsis, severe pneumonia, and ARDS. But a lot of the patients had a lot of overlap with these kind of host response characterizations too. And then another big challenge, and this is a study that we did across the VA among all patients that were hospitalized. We looked at a diagnosis of pneumonia across a hospitalization from the emergency department to discharge. And that many patients who start out with a pneumonia diagnosis actually change to other diagnoses across their hospitalization. And it goes the other direction too. And so over 50% of the patients hospitalized across the VA with the diagnosis at some point in their hospitalization had a change between the diagnosis placed in the ER and the diagnosis placed in the discharge. And then 36% who start with a pneumonia end as a different diagnosis, and 33% start with no pneumonia diagnosis and end as pneumonia. And this kind of big shift has a big kind of implications on observational studies that use diagnosis codes if they were placed at the end of discharge. You're really not studying those patients that are initially treated for and diagnosed with pneumonia initially. And so that's kind of an important thing to think about when we're thinking about kind of using large data sets to characterize, observational studies of kind of big epidemiology of pneumonia. So did we learn anything from the pandemic? I hope that we did, and I'm really excited to hear some of the other lectures that have lots of really cool, interesting stuff on viral pneumonia. But this was a graph that I put together halfway through the pandemic. I started doing some education across the VA system for clinicians in the front lines, and the top time series plot shows just the number of daily cases across the United States. This is from the CDC. For the first couple of years up through December 20th, 2021. And you can see, kind of rise in the surges across the United States. And the lower time series plot shows the number of deaths. And what I like to point out with this is lots of different events that we had going on in our country during this time. But the lower graph, you can see that we had a lot of deaths in that first surge across the United States. But then it seemed as though by January 2021, we were starting to have slightly better outcomes. And, that could be something about the patient population, it could be something about the variants. But we were, I think, learning some things too. So a couple of really important things is, you probably all remember, is we had some early trials of remdesivir. We had early trials of the recovery trial of steroids that really helped us potentially manage those patients with severe COVID-19 better. Also, we noticed, I'm an ICU physician, so we had quite a bit more comfort with high flow oxygen use rather than just intubating people really early. So that was another thing that I think we learned. And then we were also kind of exploring other ways to modulate the immune system. And so a couple things that possibly we learned, so by the end of the pandemic, maybe we were a little bit better at managing COVID-19. And so my preliminary work, we're actually looking at the impact of the pandemic on pneumonia care. So that includes COVID-19 pneumonia, but also other all kind of pathogens, and across the VA system. And so we're characterizing a cohort of patients that starts in 2015 and is kind of a rolling data set across all the way to present. And so what the results I'm going to show you is just kind of a few interesting trends that I think are kind of cool, that looks at just practice and outcomes and kind of the patient case mix that changes over time through the pandemic, but now to kind of, dare I say, post-pandemic. And so we started with all emergency departments across the VA system. That was 19 million during this study period. And that represents 3.7 million actual veterans. They have lots of repeat visits. And then we identified among that 690,000 patients with the clinical diagnosis of pneumonia. And this is important. We use ICD codes, but only the ones that are placed initially. So we're really trying to look at that initial management of pneumonia in those patients that are initially diagnosed with pneumonia. And we use coding, but we also use natural language processing of clinical notes to identify the diagnosis of pneumonia that's placed in the emergency department by the emergency department physicians. And so our final population, after excluding repeat visits, is about 600,000 patients. And here's just kind of what we saw with trends in treatments, and I'm going to highlight a couple of these things. So on the left panel, you'll see patients that had a clinical diagnosis of pneumonia, but also had a positive chest image. And so not all patients with the clinical diagnosis have a positive chest image, even though they probably should. And so this is actually kind of a refined kind of cohort of those. And then the right shows you what happened with the patients who were hospitalized. So those are kind of two other ways of refining kind of the sick people with pneumonia is on the right. And so if you kind of follow this purple line, this is basically an interesting trend, I think, is that very few people who had a positive chest image and a clinical diagnosis had no antibiotics. Almost all of the patients, around 92-93% of all patients prior to the pandemic, received antibiotics. But if you look at what happened after COVID, a lot of people got more comfortable just holding antibiotics for patients with COVID-19. And now we have kind of a new baseline. So if you take a look over here, after 2022, this is kind of settling into a new baseline. And some of these patients represent patients with COVID-19, but some of them actually just represent patients with maybe other viruses or other patients that people feel comfortable holding antibiotics. And then among the hospitalized patients, you see the same trend over there. So there's an increase in just withholding antibiotics for patients with the clinical diagnosis of pneumonia. The second thing that I think is interesting is there's a decrease in kind of what we have as guideline concordant standard combination therapy. So that would be a beta-lactam and macrolide. And most of our patients across the VA system have comorbidities, like almost half of the patients in our system also have COPD because they have a lot of smoking. So it is kind of common to use standard combination therapy. And so you can see among the positive chest image patients, about 50% of those patients had standard therapy, but then there's kind of a dip and possibly a little bit decrease after the pandemic. And you see this also with the hospitalized patients. And then the other interesting thing is that there's a slight decrease in broad spectrum antibiotics, but not as much as you might expect. And so still patients with positive chest imaging, hospitalized or not, About 20% of them were getting broad-spectrum antibiotics before the pandemic. It dipped a little during the pandemic, and now there's maybe about 15% of the patients are still getting broad-spectrum. So that's anti-MRSA or anti-pseudomonal antibiotics. And among the hospitalized patients, you kind of see the same trend. There is a little bit of a decrease after the COVID-19 pandemic. And then we see, I also looked at steroids, so the use of steroids. Of course, you can see kind of quite a big jump during the COVID-19 pandemic after the recovery trial, but there is a slight increase in corticosteroid use after the pandemic as well. So these are just a few interesting treatment changes that I've characterized. And the other interesting thing that you can see is that this is not a uniform change across the entire system. You actually see quite a bit of variation by facility. And that's another really interesting thing, is what's driving that variation. Here's just, since we're kind of talking about influenza a lot, I thought I'd show you some changes in virology and microbiology. So the green line there, that kind of teal, is influenza. You see it sort of disappears during COVID, but now it's back, kind of with a vengeance. And RSV, you see quite a bit more rare, but you do see a rise in RSV after the pandemic kind of starts to settle. We also see a lower use of blood cultures, and that's really important when you're thinking about how many patients actually have positive cultures. That's stably pretty low, but there is a drop in the use of blood cultures. And then similarly, there's a drop in the use of respiratory cultures across patients with pneumonia diagnoses. And here's the outcomes. We can follow patients up to a year after the pandemic, or after their hospitalizations and ER visits, and you can see 30-day mortality was actually decreasing prior to the pandemic, and then rose a bit with COVID-19, and now is kind of coming back down to that stable sort of very nice improvement in mortality across our system. So we also like to mix our quantitative data with qualitative interviews with providers, and that's a mixed methods approach that I'm trying to refine to kind of understand variation across different systems. So at multiple VA medical centers across the system, we also look at their qualitative, talk to doctors at all of these different facilities. And here's just some illustrative quotes. One thing that people said changed a lot is that they now all have availability of rapid detection of viruses. And so here's some kind of highlights these respiratory viral panels that we have now that uncover 20 different viruses. And then the epidemiology of COVID, we got so used to seeing COVID positive patients, we got more comfortable with not giving people Vanc and Zosyn. And some changing practice norms. So one pulmonologist said, I think I put a lot more respect into vaccination status. So that's an interesting practice change. And then a hospitalized said less antibiotics and less duration. That's been helped by the diagnostic certainty that viral panels have given us. So kind of detachment from the antibiotic use. And then a critical care physician highlighted that hesitation to intubate. So feeling a little more comfortable not intubating people early for pneumonia. And this is another thing that I'm studying with an anthropologist and a psychologist, is the mental models of disease, and are those changing over time? Bacteria, these are just sort of what the mental models for infectious disease, critical care physicians, and hospital physicians think about, that what really causes pneumonia. And so we like to think about that when we think about their practice and are relating those mental models to their practice. And here's a few other things that drive practice change. What we've seen in the past when we look at antibiotic use is that it's very social. It's very much influenced by the different kind of providers that are a social network. And so we try to pick up on that with our interviews. So you can see that for both antibiotics and steroids, the big influence is our colleagues. And stewardship is very strong in the United States. Every hospital across the United States has a mandated inpatient antibiotic steward. So the providers get a lot of social pressure from antibiotic stewardship to reduce antibiotic use. They also we highlight attitudes toward guidelines. There are kind of changes, I think, actually in kind of our trust in guidelines, that maybe guidelines have a lot of expert opinion, but it's not really that expert. And then there is this kind of concern about the evidence base, that, you know, there's a lot of patients that we're misdiagnosing, there's heterogeneity, and they're highlighting that. And so that is kind of another reason that patients might have different care in different settings. So in summary, we've seen across the VA healthcare system in the United States lots of changes in practice, particularly around antibiotics. More patients are treated with no antibiotics, fewer with non-standard regimen. And then there's still a lot of broad-spectrum antibiotics out there. But providers are reporting changes due to some advancing technology and pandemic experience. So the viral test availability has been huge. There's a lot of social pressure, senior or peer colleagues, and local guidance, and I would also say antibiotic stewardship. Mental models may be changing, but what drives this variation in practice is not yet clear, and that's kind of the subject of our work. And whether these practice changes are good or bad are also yet to be kind of determined. And so that's also another, what is the best practice? So. And that's the end of my talk. I really appreciate your attention, and thank you very much. Definitely please email me if you have any questions. Thank you.
好，非常感谢。抱歉，因为他在录制的时候，可能那个。
I'm sorry, maybe there are some noise. Last speaker.
As he is in a training program, so he is presenting in a pre-recorded format. So we would like to thank the last speaker of today. Hello, everyone. It is an honor to participate in today's meeting. The topic of my presentation is Integrative Medicine for the Prevention and Treatment of Severe Infections Cohort Studies. We know that for severe infections, it is a major challenge for the clinical treatment in the entire diagnosis and treatment. We have three major difficulties. The first one is difficulty of diagnosis and treatment, high mortality rates, and overall high medical costs. The second aspect is the complexity of the entire diagnosis and treatment environment, complexity of the patient's condition, and also the entire process of the progression of the severe diseases. So in such scenario, we still need high quality evidence, especially in this complex environment and the population of the patient, how to achieve personalized intervention and diagnosis. This is a major issue that we have to face. Severe infection is so important. So the first one is the VAP, or ventilator-associated pneumonia. We have found that in the ICU patient, 90% of the patients who use the ventilators will experience different types of the infections. And then on the other hand, even though this is a very common issue, there is lack relevant evidence-based study. Through previous analysis, we have found that both internationally and also in developed countries such as Europe and America, relevant guidelines are mostly based on low quality evidence to make relevant guidelines and recommendations. Another aspect is that in severe affection, multi-drug resistance or MDRO is a huge challenge we face. Due to the prolonged exposure to this intensive care environment, the MRDO will occur, and effectiveness of the Western medicine treatment is limited, and there is no specific drugs, etc. So that's a major challenge, how to address these challenges. The integrated treatment of both the Western and the Chinese medicine, especially with the support of the Western medicine or the treatment of the antibiotics combined with the traditional Chinese medicine, may become an important complementary approach. From previous study, we have found that some CTM will play a role in anti-inflammatory and immune regulation. They can demonstrate the complementarity effect, and they can better prevent or control the occurrence and evolution of multiple drug resistance. So in response to these above issues in such a complex and severe scenarios, etc., how to effectively control and treat the overall hospital infection in ICU is a major challenge. And our team has formed certain foundation after several years of work. So the basic idea is that in this ICU environment, we need to form a specific data foundation so that we have a multiple or multimodal data cohort for the severe illnesses, and then focus on the risk prevention and control of the VAP. We can build the measures to control the risks in order to reduce the risk of infection. And also through the integrated the Chinese and Western treatment, we can identify the effective traditional Chinese medicines benefits, and we can improve the treatment of the patient with MRDO. So the above work is mainly based on the interdisciplinary technology such as psychology, real-world study, AI, and also the biotechnologies, etc. First of all, we built a multi-mode cohort that is generally high quality, large sample, and multi-center. In this process, we have encountered a lot of problems. For instance, the data exhibits the multimodal characteristics, and they are scattered. On the other hand, these data are generated at a very fast time. So it is a process of high sustained characteristics and changes. At the same time, due to the existence of some records of such cases, the data may be a non-standardized process. So further technological innovation is needed to address this challenge. So based on the model, from the underlying model to the integration of the data and also the standardization or processing of the data, we need to build this kind of methodology framework. So we proposed the cohort building technique. Then in this process, we need to deal with some key variants. For instance, the concentration syndrome, which is actually very difficult to standardize because in different scenarios, different doctors may evaluate and diagnose them differently, and this will lead to many differences. We need to identify and standardize these key variables. We have further established a set of processes and methods around the identification and standardization of these key variables. Just now, we have mentioned some complex variants, and we said that we needed to have the algorithm for the complex variables mentioned earlier, including the variable concentrations and etc. For such standardized data, evaluation is needed for two aspects, the quality of the metadata and the quality of the data governance, in order to establish a complete set of standards so that we can apply them. As we are based in West China, so we based ourselves in different medical institutions in Wenjiang, Tianfu, and Xiamen, etc. And then we built the severe case cohort based on the above mentioned methods and also data sets. Of course, we see that this is relatively large amount of data, sometimes even twice as large as the data from well-known mimic we're currently familiar with internationally. So in terms of the data quality and the standardization, we are among the leading players. And also, we have covered the treatment of the CTM and the Western medicine. So we have formed a relatively complete data system because we have the information from both the non-drug related information. So for this data system, we focus on two things. The first one is the VAP, just as we mentioned just now, the patients are complex and also the intervention is diversified and that they are prone to faster changes. So we need to the situation where the scenario can be complex. We need to determine what are the reasons that lead to the VAP. So what are the reasons lead to the hospitalization infection? The recognition and control of the infection is very challenging. And we have established the whole system covering both from the risk monitoring to early warning to the entire control process, etc. So basically, in this cohort, we have found that among the ICU population, we know that the VAP has a high incidence rate, and we need to identify the sources. Once the fact established that there is the VAP infection, then based on this cohort, we have found that once VAE found it in terms of the resource of the resources and also the ventilation, the duration, and also even the mortality rate and etc., we need to identify the sources, and also this is a point of the control for the risk. But what led to these problems? So we further conducted a study on such trial cases to explore and discover recent factors. In the early stages, we may found that probably it's a complication of this patient, but later our research found that the overall factors of the patient did not have a significant impact because these patients were generally very complex. So the impact was not on. The real impact comes from some issues that existed throughout the quality of the diagnosis and the treatment, etc. And because the reasons can be very complex, it is very challenging for us to diagnose it. So in response to this, we have developed a specific method designed for the ICU population, which is based on the cohort. Through the study of the nested case, we introduced control and analysis of the time-dependent variables. And finally, we control factors such as human patient intervention and actual disease progression, etc. After controlling for these factors, what remains is actually the relationship between the risk points of the target we are concerned about or the target factors and the final outcome. So through such a tool or a method, as mentioned above, we have identified some reasons of the VAE, for instance, blood transfusion, and also, for instance, sedation, etc. If the sedation is stronger, probably it will lead to more problem. The third aspect is that we have confirmed the positive balance of the liquid, which increased the risk of the VAE. If it is a negative balance, maybe this is a little bit better. However, once a positive balance of the liquid occurs, the mortality rate will increase relatively quickly. Through the deep learning, etc., we have established the accurate fluid replenishment of the ICU. We want to verify whether the prophylaxis can be improved. Through the above related information technology research, identification of risk points, and also ultimately searching for the relevant risk factors, we have built some recommendations for the prevention and control of the VAE. Of course, some of these factors are recommended, and while others we believe should not be used. So some of the research results have been formed. On the one hand, we also provided feedback to the clinical practices. We do believe that's valuable. And also, they are effective. On the other hand, the research result we obtained has also been recognized by some international organizations. For instance, the American Hospital Infection Association and also International Infection Association, etc. They have adopted our approach in their tool development process and also incorporated them into their entire quality guideline recommendation process for the research. And also another key issue is that once the infection happens, and MRDO is a major issue, and this is a tough nut. We know that the integrated of the Chinese and Western medicine might be a good method, but because of the concentration of the diseases and also the complexity of the administration, etc., and also the progress of the diseases, what we see right now, whether the CTM works and how, it remains unclear. So it's very difficult to confirm the efficacy of the CTM. And we have carried out some work at the early phase. For instance, we analyzed the entire medication model for this traditional Chinese medicine and Western medicine. And we have seen that there are differences throughout the entire process, such as in the use of the CTM and Western medicine, and also it undergoes some significant changes over time. And we have faced a lot of challenges, and they have not been really properly addressed. So right now, the efficacy of the CTM, especially among the severe infection patients, we don't know the results so far, or at least the benefits have not been fully recognized. Right now, we are doing the systematic research to describe the medication patterns in the entire population through the systematic approach. We have found that for the West China medical system, we see nearly 1/3 of the patients are actually using CTM, especially infected patients. And for the patients with severe infections, for instance, they are using such as chai hu, or the root of the Chinese thorough wax, or the Tairenqing, etc. So maybe there is a phenomenon of treating different diseases with the same medicine. So then that's a question. How can we truly know certain types of the CTM or its usage in such complex scenario, especially when the time and situation is so complex? For Tairenqing, this is an example, and we have done a lot of study regarding it. For instance, for such a patient, according to the occurrence of the drug resistance and the absence of the drug resistance, we distinguish them. and we look at the changes of their medication, we have found that there is actually such a patient with the multi-resistance. The medication situation means that they are not only using the 痰热清, but also they are using some other types of the antibiotics and etc. And we have seen the dark blue line. That's the part. So it's very difficult to solve this problem because the scenario is so complex. So what we do is that we have this integrated CTM and also Western medicine evaluation system. So based on this method has already been published. So looking back, for instance, when we come to 痰热清 evaluation, we found that when it is used together with antibiotic, can reduce the infection of the drug resistance or the MRDO, but it does not work for all the MRDO. It only works for a single strain of the CRKP. So we can accurately locate its role on the one hand, and on the other hand, we need to clarify its role in different population. On the other hand, we can use the same method to show that 痰热清 can be used among other severe infected patients so that they can reduce the length of the utilization of the ventilators. And on the other hand, it can reduce the mortality rate. So in terms of the credibility, we can do more to prove that. So based on the above mentioned research, we have innovated this methodology and technology, and to a certain extent, we have clarified the positioning and the role of the 痰热清 injection in the entire severe infection through the combination of the CTM and Western medicine. We have conducted some basic research to see that they can solve the problem. Of course, the multi-pathway and multi-target of the CTM still face some challenges. So today I haven't present the related research result. This is my last slide. What I want to mention here is that in terms of the integrated treatment, there are a lot of questions yet to be answered, as the scenario is complex and the technology has a lot of challenges, etc. So we are bringing different technologies to address these concerns. Our work in the earlier period has shored up our confidence. We hope that we can do more in this regard. We hope that we can count on your support. So that is all from me. Thank you so much. Thank you, Professor Sun Xin. So I would like to thank all the participants. I would like to also to thank you on behalf of David Hui for chairing this session. I would like to thank all the 8 speakers and all the participants. So that brings us to the end of this morning session. There's a lot more to come in the afternoon session. Stay tuned. Thank you.